first off, anybody have any thoughts on this article? Likes, dislikes, general feelings?
It seems like this, Anita, it seems like this is what we live in, this is what we're dealing with right now with the COVID stuff. I see a lot of the stuff that was talked about in the article as
Yeah.
what is our new norm and this reality. And the article is very timely for such a time as this.
Yeah, Kristen had emailed me this article, but I agree that I thought it was a very timely topic, so I decided to use it for this month. So good, I'm glad you guys agree. So I just have some of the guided questions. I think I've said this in past journal clubs, but these are from the AOTA journal club toolkit, just to kind of help us discuss and dig into the article a little deeper. All right. So just in general, what questions were the researchers trying to answer?
So they were really kind of comparing two groups, with those that had an earlier intervention with PT and OT in ICU versus those who were not, and took more of that traditional route where they weren't started on any sort of therapy. And then they looked at some functional outcomes as well as delirium and things like that. And then they assessed, days on vent, all sorts of other additional qualifiers.
Yeah, it seems like they gathered a lot of information. I liked a lot of the different charts that they put in there, just describing the interventions or the intervention group and the control group, and what the outcomes for each of those were. I thought those were really helpful in reading along. Did anybody have any interventions or findings from this that surprised them?
I just thought it was a little interesting that they didn't use any self-report measures at all. I know a lot of, right now in research, we are trying to kind of turn to a balance between clinician-led measures and self-report measures, because that's important too, what the patient thinks or the participant.
I wonder if that was because it would have been hard to gather that in the beginning stages.
That's fair.
With this population, especially it sounds like some of their interventions were starting at a passive range of motion phase, how to compare and contrast that from start to finish.
I wondered the same thing though with sort of where they're Barthel pre-post, because they mentioned that some of them were eliminated or excluded from the study based on their prior level of function or advanced stages of dementia or something like that. But I wondered if they were able to gather a caregiver report from particularly quality of life or specific caregiver or family member type of assessments that they could kind of report, so you could get a pre-post.
That would have been a good
between, because I think that are within, because they really were looking at between group differences, not necessarily within the group differences.
I agree with what you said, Becky, when you were saying about it would have been nice to have a prior level of function before all the things happen beforehand. That way you have a better outcome or better finding on what the person's level like. And then the way the article was, that was not provided. But it'll been, as OTs, we always constantly look at that too, prior level of function, so we can know where they're going to go And
Did they start, all of their people started at independent prior level of function?
Yeah, it said they were, you know, pretty independent, but I still,
Like you mean like having like a birth, some sort of family report of more specifics on that independence?
exactly,
Yeah.
or even it particularly with related to their delirium,
Mm-hmm.
because because they excluded patients with advanced dementia, but that doesn't say anything about if any of their population in the control or the intervention group had a mild or moderate dementia beforehand. Um, that was,
not stated.
yeah. And so I was like, well, I would have liked to see some, even if it was obviously if they're going and they're sedated, like you can't necessarily get their report of it, you know, if they're in that state, but a family member, caregiver, whatever, that type of information, I think would have been really helpful to look at those within group pre-post differences.
For sure. Yeah, I think that's very reflective of right now, though, because you know a lot of our patients don't have those family members or visitors around that we can ask. You know,
Correct, because they don't let them in.
yeah, they're not. You know, nobody, or pretty much everywhere I work is having no visitor policy unless someone's hospice level. So you know, we don't have those family members, and sometimes we're able to contact them, but sometimes we can't.
Mm-hmm.
Yeah.
This,
I don't know if you're going to talk about this later in the methods section, but one thing that really stood out to me was they didn't mention speech therapy at all.
Yeah, I had that. That was a part I had written down too. That speech wasn't something that was focused on.
And I just was like, oh, really?
that was a big component, especially in ICU, especially
Right.
with cognition and all that.
And even with events, going from event to a trach,
Right.
you know, with speech production, cognition, swallowing, all of that stuff, I was really like, oh, it would have been interesting if they would have been involved. And I didn't know why they chose that or not to.
Yeah, it at least would have been nice to have some of that information in just the report, like even was the control group getting speech versus how much of the intervention group was getting speech, just as a comparison to, just, you know, that might have impacted the study. I think that's kind of limitations. Let's see what I have next. So yeah, we've talked about a little of this. What methods were used for answering the question they proposed? So we've already said they compared the intervention group to the control group.
I did like how they blinded the therapists that were doing the assessment versus the intervention. So they were completely, those that were coming in and doing the assessments every, whatever it was, 48 hours or something, they didn't know which group, which helps. I did have another question in terms of if there would be any sort of training effect, because if they were having both PT and OT like within the same day, did they randomize that? Did they do PT OT all the time? Because we know that sometimes people do better in the morning versus later. Did they randomize that beforehand and stick to that? Or did they just do the same for everyone? You get PT at this time, OT at this time? Or did they not account for that at all?
I don't think they account for that.
I think that was one of the things they mentioned in the study limitations for some of that learned effect.
Could you repeat what you said, Kelsey? I didn't hear that.
I said that was some of the things they mentioned in the study limitations, was some of that like learned effect. Yeah, I don't think they specified for either the control or the intervention time of day and order, whether PT, OT got to them first.
That makes a big difference in the outcome too, depending on what the time was. They had them to do it all at the same time, or what else is going on with the patient too, and that wasn't stated in there also.
Yeah, and toward the end of the article, they indicate that procedures, like scheduled procedures, or being off the floor was a reason for missing therapy. But it made me wonder if like they didn't do traditional like sweeping of the unit repeatedly to try to get the minutes in or the attempt in. So that's curious. I also wonder how they did that all.
Mm-hmm. Yeah, for sure. And like, what would be the difference between that and the control? Like, was that something the control group was doing to get their time in? All right. Marissa, do you have anything on the statistical methods? I always consider you like my statistics expert.
I mean, odds ratio is pretty straightforward. It's like, the odds of, like, let me find an example from the article instead of just pulling one out. For example, like return to independent functional status. At hospital discharge, the odds ratio was 2.7. So for the intervention group, they were 2.7 times more likely to return to independent functional status than the control group. That's kind of how you read an odds ratio. It's, not quite as something that we use as frequently, but it makes intuitive sense.
All right, we've talked about a lot of these things, but what were some other limitations of the study that they mentioned in the article, or that you felt like there was from reading it?
Outcomes at the discharge planning made a big difference too. The discharge planning, where they left, they went.
Yeah, I think one of the things is just like we talked about it briefly, but the learned effect, because they just used, functional independence. So was that something that, the therapists were teaching compensation strategies, and they actually just like learned a new way of doing those things? Or was it something that they actually had a strength gain? I think they mentioned, in particular, because there was no change for the grip strength scores between the control and the intervention group.
I thought it would have been, I don't know, maybe just a little nice big picture sort of thinking, in terms of, because they didn't really differ between the total length of stay, like in the ICU number of days,
Yeah, or the
Um,
hospital say that was one thing that really surprised me.
so again, I didn't know if they would have broken that down a little bit for, like, because did they go from a vent to a trach, and were they on a trach for a longer period? What was the reason? And then it would have been, I don't know, in terms of, I mean, unfortunately, the world we live in, healthcare is a lot about money. Yeah. So did that save the hospital or Medicare or whatever insurance? Did it save any money by being on the ventilators a less amount of days? Or the patient money, the cost of the daily care, but if they're in there the same amount of days, then maybe not. It would have been nice to kind of have those numbers just kind of assigned to that.
Yeah, for sure.
Or even if they had some complications in between there, I was aware of that being clear too. In between the time they was on the vent, they have any complication that they had to call them be more sedated or whatever. So I didn't see that in there either. I think that makes a big difference too. How they was weaned off and on from the trach, from the vent, I meant.
Yeah, I talked to somewhere on the breathing trials, and I was just curious in the control group, and this is just kind of from my own personal experience. Sometimes as like when I'm working up in ICU, I get a lot of pushback on therapy when they're doing the breathing trials. They're like, oh, they're doing a breathing trial today. Can you come back tomorrow or this afternoon? That's like, they feel like that's too much for them. I don't know if anyone else has that same experience, or because this clearly indicates that it was supported well, that it went together.
I think you do see that because people want to give the patient the opportunity to perform their best, which is, I can understand that, but it also can set us up for like a misrepresentation of what it's really going to look like when they're doing transfers or any other setting up to be with their family, and how that's going to fatigue them. And here we're only doing, vital capacity or whatever it might be at the time when they're at their best or have been resting the longest, so then they're able to complete it.
Yeah, because even sometimes it's like, oh, well, they're doing a breathing trial this afternoon. Don't wear them out today. I'm like, well,
yeah,
we're really just, can I sit them up on the edge of the bed? Like something.
Yeah, good news. You don't have to breathe to pivot to the commode, apparently.
That's not important.
We usually try to do a combination, maybe because of the early mobility that's going on at the hospital I'm at.
Okay.
And we always have the respiratory therapist right there when we're doing the things, even when they go into their breathing trials and all that. We try to do a combination of it. But then again, it depends on how they responded, how long the breathing trial was going on at the same time. So it's a combination of this, really the experience. I'm not trying to be funny, but the experience of the therapist knowing that, hey, slow down, can't rush this, or a combination of PT and OT going in at the same time. We know when there's two not hand therapists, but two
skilled
field therapists working together, it makes a big difference. And that would also account with the breathing trial. You're not wearing them out as much. Both therapists are coming in at the same time, but working on different things because we are different. At the same time, the time span is shorter and give them a chance to rest in between the day.
Mm-hmm.
Yeah, many years ago when I worked in the LTAC, and granted, of course, our vent patients were, I mean, they weren't acutely on vents. I mean, they were on them for quite some time. But we worked very, very closely with respiratory therapy, and sort of it would be like all hands on deck, but we had really phenomenal RTs. I mean, they would ambu with us, like
Yeah, I
And
think a lot of it's building that rapport and then understanding how we can really benefit that patient of, of doing both at the same time.
That's
yeah,
why it's so
go ahead.
That's why it's so important. I'm an old school therapist. I would say more like seasonal. I won't say old school, but seasonal. And I am from Chicago, so it's funny that we use this article. A lot of times it's the level of experience. A lot of times, the ICU nurses are very protective of their babies in ICU. That's why it's so important to gain a rapport with the nurse and the respiratory therapist. And that's where the whole interdisciplinary team come together. So if you're thinking I can go get this patient up by myself, the reality is no, let's do it together. And there's also planning that out. So this would be their goal for today and setting realistic goals and practical goals, especially as it's being OTs. We are functional. We just don't walk. We're functional by doing something and documenting that, because that's the reality. I think you spoke of that earlier, the importance of this is the real world. We're trying to get them out of ICU, especially with the days of being in ICU. So they won't have to go to LTAC.
I think part of that also comes from just being in a resource-rich environment. When I was practicing out west, they had a gap in when there was occupational therapy in the ICU, and so it did take a while to build that rapport to your point with the nursing staff. So they have to understand the role of OT and the potential that we have, and that even to have a sedation vacation occur when you're going to work with them, they have to know, like you said, that you're coming and coordinate care. So yeah, so much of it is about relationship and effective communication amongst the team.
Sure. So one of the questions is what interventions do the researchers suggest? I don't know if they really had like specific interventions, but was there something you guys felt like you took from this, other than they're obviously suggesting PT and OT at an earlier stage, but something you took that you would apply to your practice?
It reminds me of when I don't think you hear it as much anymore, but I remember when I was in my first level 2 in the neuro ICU, I would hear the physical therapist talk a lot about, and same with the OT as well, the partnership. They would talk about whether or not what they were doing today was real therapy, and they would kind of use that rhetoric a lot. And I don't think that we see that as much anymore, because early mobility is functional therapy. It's pre-functional and it's recognized as that now. But I think at the time when this was occurring, that was a relatively novel concept, and it was hard to get people to buy into the fact that like we have a place there. It's not just about getting nursing to dependently transfer to the cardiac chair or whatever it is that the hospital decides to use for safety.
So, Kristen, you were talking about the article was written in 2009. So hopefully the study was around that time too. So therefore, I know the University of Chicago was doing some early mobility at the time. I think early mobility is more. At that time, in 2009, they was doing more of early mobility. I think it was really starting off.
Yeah, I think it was probably one of those things that people were doing naturally, but hadn't been tracking, and so then it was kind of, because I was at St. Luke's in Milwaukee at around the same time as this article, and, it's what we were doing, but it wasn't necessarily, I think.
I like what you said, that it wasn't documented.
Yeah, we didn't record it in the same way. We didn't talk about it in the same way. It really wasn't, we hadn't really formed how we wanted to propel this concept.
That's a good point.
I think they kind of mentioned it on the last page too, like that they're even within the control group, like at their particular facility, people were getting therapy at a higher rate than than other places that may have those gaps in therapy. Does anybody work somewhere where they have like an early mobility team? I know one of my hospitals does.
I'm out of Austin, and they do have an early mobility team.
Cool.
I'm in the process of trying to move to Georgia. That's why I end up joining.
Oh, awesome. We're glad to have you.
Yeah. that's why I'm doing this. I'm really trying to feel the Georgia people.
Welcome.
So when Chris Kelsey told me about it, I was like, oh, I joined. So again, at St. David's in Austin, Texas, they have a whole early mobility team. They even have a program for early mobility, and like nurses and everybody know you down there. And we're slowly introducing a lot of the new therapists. Everybody has to rotate. Like, you know, in ICU, some people are just afraid to work in the ICU. They don't feel comfortable. So they go with a tag team, a PT and OT who is stabilizing that station in that area all the time. And people are slowly coming in there to cover. So it makes it different when the same people are doing it.
I know Johns Hopkins, gosh, it's been several months back, maybe back in the fall, they did, instead of like a walkathon, they did like a functional-a-thon. I forgot, they had some catchy name for it, but it was all around early mobility. And one of the things was like getting people out of hospital gowns even. So they had people putting on real clothes, like in an acute setting, and they measured like laps around the unit and gave prizes, and it was like all throughout the day, like it was like a whole maybe 72-hour thing, and you could log on and they had different webinars at different times to like promote this whole concept. It was pretty cool to see, and they were having like other hospitals around the country join in to support the idea of early mobility and function.
That's wonderful. I think there's so much power in having someone get back into like what would be considered like traditional clothes and not sick clothes, because just from the family buy-in and the way the family approaches the patient and the other people seeing them in traditional clothes opposed to like the gown where they're not fully clothed and
Yeah, or putting them on backwards to cover their back.
Yeah, I actually read a couple of different studies. I think they were out of the UK, that they were actually looking at the like a lot of the psychosocial effects of that hospital gown itself, and those perceptions, not only for the patient themselves, but the family members as well as healthcare providers. You know, they viewed the patient as more debilitated and helpless almost wearing those gowns, and then the patient's really negative attitude, you know, like, and depressive, almost like creating this, you know, like, and they're self-conscious because, I mean, it's not covering. It was a really good study because they were also looking at how sometimes those gowns are also very inappropriate for those that may not feel comfortable because of cultural reasons,
Right.
because of clothing attire. And they were also then looking at like redesigning the hospital gowns, or like how could there be alternative gown options for different populations, but still give the access to
Line tubes.
lines and accessories. The only other thing that I thought it would have been really interesting, and I didn't look up to see if they had if there was any follow-up, like did they follow their groups whatever X amount of time, either in their post-discharge like setting, or in 6 months from now, if they were home or whatever, what was their level of independence, or what were some of those outcomes then? Because in the long-term effects of kind of being in ICU and on a ventilator and things like that, which is a lot of where we're at now, like in home health, a lot of my colleagues are saying that post COVID-19 hospital discharge patients, they're very, you know, your typical acute respiratory failure type of thing. And I'm like, well, of course, of course they are. But almost even there's this other piece of it because of the restrictions of the pandemic, which differ, and just some of those other all of those components that go into it. But overall, just very, very weak and needing a lot of energy conservation and breathing, pursed lip breathing, et cetera, et cetera.
That would be a good study to do. With COVID patients, how's the outcomes after what do you provide them?
The other,
Especially even while.
yeah,
Sorry,
the other thing that I'm hearing a lot of is they're being discharged to home because they're still being denied, even though they would prefer them to be in a subacute or a SNF, they're not accepting them. So they're being discharged to home and they don't need to be there. It's not an appropriate setting for them. And then we are seeing some pretty significantly declined patients in the home anyway, but with this, it's even more so where they, and then that runs the risk of all the complications that come with not being in the best setting.
And I even correlated this, supporting that, the idea of early mobility, not as much, I'm not seeing as much now, but initially, because they were trying to limit the number of people going into those COVID rooms, they were very resistive on therapy going in. It was like the minimum amount of contact. It's gotten a little bit better. When they start to have those discharge issues, that's when they're like, okay, we'll bring you guys in now. And it's like, well, we really needed to be starting earlier. I don't know if that's anyone else's experience, but that certainly was mine.
I haven't worked with the COVID patients yet. At St. David's in Austin, we have sent our COVID patients, anybody positive COVID, go to one of our other St. David's hospitals. Only because we get prenatal patients at our hospital, and they don't want that nowhere near the babies. That's very interesting. But I know a friend of mine who work at Mercy Hospital in Chicago, and they're in the rooms with the COVID patients. They're doing treatment.
Yeah. I haven't been in acute as much recently, but there's definitely therapists in there, but especially that ICU level vented patient, they tend to be more resistive to therapy.
I think a lot of it has to do with what the hospital perceives as the volume of PPE they have as well.
We also ran out of masks, so it was like doctors are sharing, so we really don't have the PPE to go in.
Yeah. And if they're going to pick a discipline, if they're not as familiar with OT, then we're not necessarily at the table. You know what I mean? Like, I think it is, if they're trying to triage the amount of equipment they have, it gets complex. People are in situations we never thought we'd be in.
Yeah. And this was like one particular case, and this is in the very, very beginning stages, when the hospital had a couple cases, and the nurse basically called the PT, and she essentially did telehealth over the phone with the nurse of okay, this is what I need you to do to limit her going in.
Yeah, I've heard speech therapy do that with the nursing as well for that same reason, or some hospitals actually converting to that format entirely for therapy until till their levels of other equipment and things leveled out. It's wild. It's really wild.
Yeah. So we have a couple minutes left. I just wanted to go over how you guys get your continuing ed. But does anybody have anything else they want to add before we go into that? Good job. Let's see. Okay, I was gonna just kind of show you. I put a link here. So you're gonna do it all through the Journal Club page on the website.
Okay.
I think I left it up. So you have to be logged in. I think most of you got here to see the article. I got a couple emails back about people who are prospective members, and they're not able to see the page. So if you hear that around, let me know. But yeah, so if you're on the Journal Club page and you scroll down, there's all the months. So if you want to go back and look at previous articles. All the articles are there, as well as the discussion notes and the YouTube videos. They're each categorized by month. And then May, I'll put up the notes as well as the YouTube video for this month. And then this bottom section right here that it says continuing ed forms, you click on that and it will bring you to the form to fill out to get your continuing ed. So this kind of explains how to do it. And I pulled this straight from NBCOT. It's not anything I created. So it's all like by their guidelines. There's an example and then the blank form. So you just fill that out and you don't need to send it off or anything. You'll just save it for your own records to keep. So that's how we're doing that.
Wonderful resource. Thank you for doing all that, Kelsey. The page
Yeah, you're
looks awesome.
welcome.
Thank you so much. And again, this was a perfect article for right now. It was really good.
Good. I'm glad you guys enjoyed it. I thought it was helpful. I'm always open, you know, if you guys find articles that you really like and think would be a good fit for Journal Club, I'm always open to suggestions or ideas. Feel free to send me an email.
I agree. I really liked it as well.
Good.
Hey, Becky, what was the name of that article you was talking about the hospital gowns? That's kind of interesting.
Yeah.
I would have to look it up. I'll look it up and see if I have it. I probably have it bookmarked or saved.
That was interesting. I said it was really interesting.
Yeah, if you could find it, email it to me, and
Okay.
I'll at least put it in the May folder, and then we may use it for another month as well.
Okay.
That way you guys can find it. I'll just put it in the, you know, maybe at the end of this presentation or something.
Thank you.
Awesome. All right, guys. Well, have a good night. Thanks for joining.
Have a good one, everyone.